It has become mandatory when you come across a difficult constellation of signs and symptoms. You use many artificial intelligence platforms, particularly ChatGPT. You prompt ChatGPT with the symptoms given by the mother or parents, and you will try to find out the differential diagnosis. These are all artificial intelligence platforms. Remember, nothing is going to replace the natural intelligence given by the God, the special senses given by the God, your eyes, your ears. Okay, so I am going to present a case in which how a simple bedside clinical examination by our fellows helped us in getting a difficult diagnosis and avoiding unnecessary investigations. And what is this case actually? And this is a 11-year-old child, a girl child, brought with recurrent episodes of spitting of blood in the sputum. Neither her heart is affected, heart rate is normal, no murmur, nor her lung is affected, she is not tachypneic at all. And anthropometry is absolutely fine. Weight for height and weight for age as well as height for age are absolutely fine. And there is no pallor indeed. So recurrent episodes of spitting of blood with the normal heart, normal lung, normal anthropometry, a normal routine clinical ENT examination by a residence. Whenever you have doubt whether it is a case of hemoptysis, hematemesis, or the blood comes from the nasal area, how to decode? The answer is very, very simple. When it is bright red, frothy, associated with or preceded with cough, it is more in favor of a hemoptysis and it arises from lung airway. Whereas when it is dark colored, coffee colored, associated with abdominal pain, preceded with nausea or vomiting, then it could be hematemesis arising from the gastrointestinal tract. Neither history of vomiting nor history of abdominal pain, but the child is spitting blood whenever, which is more at night and which is more when the child lies down, then it is more in favor of an post-nasal bleed presenting as coughing of sputum or spitting of sputum. Post-nasal bleed occurs more often at night and more often after the patient assuming a recumbent position. So this is point number 1. When you have a confusion whether it arises from the airway, intestinal tract or upper respiratory tract, that is your nasal cavity. Second, you need to ask the quantity and pattern of the hemoptysis or hematemesis or the amount of blood she is spitting. Based on the quantity, quality help us to differentiate where the site of bleed is, whereas the quantity will help you the etiology. So remember, you can have all these things. When you have streaks of blood with sputum, small streaks of blood with sputum, more often it is due to an acute bronchitis, which could lead to some kind of bleed from the upper respiratory tract. An acute bronchitis, significant, severe post-viral cough at times can lead to this kind of streaks of blood in sputum. Any acute bronchitis, where most often a viral. When it becomes more, rather than getting a streaks of blood, when you get tablespoonful of bleeding, which is also recurrent in nature, then the lower airway is significantly involved, not your upper airway. Lower airway is significantly involved. There could be an underlying bronchiectasis, a TB, and necrotizing pneumonia, particularly Klebsiella pneumonia, a congenital lung malformations, or an abscess. If it is a large massive bleed, it is more often from a bronchial artery. It could also be from AV malformation, pulmonary hypertension, or vascular anomaly. So first one is bright red, frothy or dark red, non-frothy associated with cough. What is the amount of sputum? What is the amount of blood that is present in each and every cough or vomiting? That is the second point. Third point, what are all the other clues that you can ask to find out if it is a case of hemoptysis? Point number one, when the child is having recurrent cough, infections, clubbing, recurrent fever, invariably it is a case of bronchiectasis due to any cause. Could be due to cystic fibrosis, primary ciliary dyskinesia, immunodeficiency, or in India TB. Bronchiectasis of any cause. But there is no such cough in my patient. 2. When the child is presenting with acute fever and productive cough, more in favor of a necrotizing pneumonia or lung abscess. Again, my child did not have all those symptoms. No such symptoms at all. Sudden onset choking episode, sometimes a retained foreign body could produce these kind of hemoptysis. Again, my child is 11-year-old girl, unlikely to have that kind of history. When you have bleeding elsewhere, cutaneous bleed, menorrhagia, epistaxis, then I could think in terms of a coagulopathy. But in my case, there is no bleeding elsewhere. Right. So no mucus bleed suggestive of von Willebrand disease, no cutaneous bleed suggestive of platelet disorder. Right. Normal, absolutely normal. When I have an associated rash, arthritis, hematuria, it could be a manifestation of vasculitis involving parenchymal and extra parenchymal or pulmonary issues. But there is no such complaint in my 11-year-old child. So no clinical feature suggestive of vasculitis. Then, is there any pallor and weakness? If it is associated with acute onset massive bleed, then the child will have respiratory failure or severe anemia leading on to severe breathlessness. If it is a chronic significant bleed into the lung, then it could turn on to interstitial lung disease and the child will be having resting tachypnea and hypoxia, but there is no such thing here. There is no breathlessness at all. So I could not think in terms of a acute onset bleed into the lung, neither a significant chronic bleeding into the lung, otherwise known as pulmonary hemorrhage. The respiratory rate is absolutely normal. So I could not think in terms of an acute massive blood loss into the lung, neither a chronic significant bleed into the lung to produce tachypnea. None, no such complaints. Epigastric nausea, melena, altered blood, more in favor of an hemoptysis, GI cause, but turned out to be, but the child is saying some kind of nausea and vomiting, some kind of abdominal pain. The child had given this complaint, some kind of abdominal pain. So the child was given a trial of proton pump inhibitor. Okay, then what is this? So finally, look at this. Look at this. This is the photo sent by the parents. It is bright red and it is frothy. So it occurs more in favor of a respiratory tract rather than the GIT tract. But there is no tachypnea. Heart rate is normal, respiratory rate is normal, saturation is normal, no clubbing. A little bit of GI symptoms were there. Small streaks of fresh sputum and it is frothy in nature. But one more significant history is the child is having little bit of allergic rhinitis and a little bit of snoring. So we were thinking in terms of two things. One, definitely it is not a lower respiratory tract bleed because no tachypnea, no clubbing, no hypoxia. Could it be due to a one which arises from gastrointestinal tract? But this is bright red and frothy. But despite that, since there was a significant abdominal pain, we treated the child with proton pump inhibitor. And since the mother is confident that there is little bit of sneezing and snoring, we were thinking in terms of either due to frequent nasal rubbing because of that itching produced by allergic rhinitis, or an adenoid which could bleed when it is infected. So the child was given a course of intranasal steroids, right? Because all our basic workup was normal. So HRCT, it was 10. To be very frank, we did an HRCT, turned out to be normal. And OGD, scopy, esophagogastroduodenoscopy, no bleeding spots, nothing, no esophageal varices. CTPNS was 10, no significant adenoid or any polyp or any nasopharyngeal carcinoma. Coagulation profile, basic coagulation profile, CBC, peripheral smear study for platelet count, clump, PT, APTT turned out to be normal. So right now I have a case of a normal well-built child often presenting with spitting of frothy brightlet sputum in blood, which is not acute to the extent of causing breathlessness and not to the extent of causing any pallor. So she is absolutely fine. The child was given a course of, what did I say, anti-reflux management, proton pump inhibitor, but it did not work. The child was given tranexamic acid, probably some vascular bleed. So we tried our level best with tranexamic acid, failed. And the child was given a course of mometasone nasal spray, failed. So all the basic investigations, now I should not say basic investigation, HRCT, endoscopy, all turned out to be normal in this case. So where is that bleed comes from? Where is that bleed? ENT opinion was also sought. ENT opinion turned out to be normal. So what is this case? What is the next best investigation? Could it be due to AV malformation that was missed in an HRCT? I don't know. Should I do an extended coagulation profile to look for factor 13 deficiency? Or von Willebrand disorder presenting with this kind of blood tinged sputum? Or is it a vasculitis so that a lung biopsy will be helpful? But I didn't have any extra pulmonary manifestation in the form of rash or arthritis or fever. Or should I do an FOB to look for hemosiderin laden macrophages? All these were planned. Then, so this case has been under follow-up for the past 3 to 6 months. Then we requested our fellows, Dr. Balaji, Dr. Saktivel and Dr. Ashok, to take a detailed examination and to look for clinical clues, because I didn't get any clinical clue with respect to history or physical examination, to be frank, directly from my heart. I did certain investigation, turned out to be normal. We requested our fellows to do further history and to look for any other clinical clues. Okay. Yes. They picked up a beautiful clue which I missed indeed. So what is that clue? Look at this. There is tortuous dilated blood vessels noticed in the conjunctiva. Tortuous blood vessels noticed in the conjunctiva. What is that? Ocular telangiectasia. When this child has got telangiectasia in the conjunctiva, she should have telangiectasia elsewhere, and the bleeding from those telangiectasia must be responsible for this spitting up of blood in sputum. So we did bronchoscopy to look for any bleed from the nasal cavity or from the lower respiratory tract, and we found out the following thing. There are telangiectic blood vessels in the nasopharynx itself over the turbinate bone. Okay, there were telangiectic blood vessels. Look at this. While doing the procedure, it was bleeding, and it was It undergoes self-resolution also. So telangiectatic blood vessels in the nasopharynx that bleeds immediately on touch with spontaneous resolution. So what is this case? What is this case indeed? This is a case of hereditary hemorrhagic telangiectasia, what you commonly know as Osler-Weber-Rendu disease. So you have a certain criteria which says that when you have three or more of the following: epistaxis, mucocutaneous telangiectasia, arteriovenous malformation involving your major organs. We are planning, yet we didn't do any genetics. We are planning to rule out our AV malformation in other organs too. And apart from that, that should be a family history. Okay. A cursory family history, when initially asked, was absolutely, as per the parents, is normal. But our fellows did a detailed provoking history and found out one particular thing, that father and grandfather used to have non-returning bleeding. They are thinking that it must be due to epigastric pain induced bleeding. Father and grandfather used to get insignificant spitting out of blood. They had the same history. So right now, even though I didn't have epistaxis right now, this epistaxis probably is presenting as that spitting out of blood. Mucocutaneous telangiectasia is witnessed in flexible bronchoscopy. Arteriovenous malformation involving the major organs are yet to be proved. But there is a beautiful family history again extensively elicited by our fellows. Right. So look here. Clinical, when the father came to us, okay, the father came yesterday. I was asking him why your eyes are like this. He told he did not sleep the entire night and he was traveling to Chennai to see her daughter. But despite that, look here, look here. There are telangiectasia. This is not a simple red eye, red conjunctiva. Look carefully, there is dilated conjunctival telangiectatic blood vessels. It is not a simple congested conjunctiva. Dilated conjunctival blood vessels are seen not only there but also in the oral cavity, hard palate. Look at this. Clinical clues in father. So, what is the carry home for the residents who are listening to this particular video? What is the carry home? A meticulous history. They were very sure that the bleeding should be somewhere non-returning, and a meticulous history. They call their father, grandfather. Okay, they took such a detailed history and a simple look into the eyes of the patients, a physical examinations. So a battery of investigations had been avoided. So our fellows, I repeat, Balaji, Saktivel and Ashok did a great job. So what is the carry home? Meticulous history taking. What is the carry home? Physical examination, looking for ocular conjunctiva. And it is, what is the final carry home to our residents? The answer is one and simple. Observation outshines investigation. I repeat, observation outshines investigations. Bye-bye.